So once again, I would like to welcome everyone. Good morning, good afternoon, good evening, depending on your time zone. And you're welcome to the second part of this webinar series. Today, we'll be looking at the global expert perspective. For those who didn't join us last week, we started with the basic science of radiotheranostics, and we had two very wonderful speakers, two nuclear physicians, one from Nigeria and one from the UK, who broke down the complex science of radiotheranostics. I'm aware that the video will be available on demand, so just in case you missed it, you can, don't worry, we'll send it to you. Just a quick housekeeping. After our presentation today, after the speaker has spoken, we will take questions and answers. So while he's speaking, you can please put your questions in the Q&A box or even in the chat, whichever one is convenient for you. And at the end of this three-part webinar series, you are entitled to a certificate of attendance upon request, and you can send that email to communications@medicaid at communications@medicaidcancerfoundation.org is on your screen. And just to introduce myself, I'm Iyobosa Uwadiae. I'm a board-certified medical physicist, and I'm also privileged to be leading the Nigerian Association of Medical Physicists. I'll be your moderator for all three sessions. This webinar is organized by two wonderful foundations. Oncidium Foundation is one of them. And Oncidium is a fully independent non-profit foundation committed to advancing radiotheranostics for cancer care worldwide. And they do a lot of work in education, creating awareness, providing affordable treatments for patients who cannot afford it, and of course, advocacy. I don't know if one of the staff of Oncidium can put their website in the chat so that people can find out more about your foundation and what you do. And of course, the second collaborator is Medicaid Cancer Foundation. It's a Nigerian-based cancer foundation founded by Her Excellency Dr. Zainab Bagudu, who is also the UICC president-elect. And Medicaid does a lot of work, of course, in cancer care, creating awareness on detection, treatment, advocacy, and all. And they are part of a larger group. So it's not just the foundation. They have hospitals, pharmacies, and all that. So together, Medicaid has collaborated on Oncidium to provide us with this very wonderful webinar series. And it was put together to answer one major question: how can Nigeria turn the scientific promise of radiotheranostics into real access for patients? But if you're from outside the country, this is not for Nigeria alone, but of course the lessons here, we're using Nigeria as a case study, but the lessons here can be applied to countries within the region and outside the region. So this is the second part of the series, and like I mentioned earlier, we'll be looking at the global perspective, and we intend to cover these topics, look at the evolution of radiotheranostics, and then radiopharmacy and building sustainable programs. Unfortunately, one of our speakers had a last-minute conflict, Dr. Masha, so she will not be joining us today, but Dr. Mahipal Rathod, I hope I got the pronunciation correctly. He will correct me if I didn't pronounce his name well, would stand in for both of them. So Dr. Rathod is an assistant director of nuclear pharmacy at the Ohio State University. He's a board-certified nuclear pharmacist, yeah. And he'll be speaking on radiopharmacy, supply chains, and what it takes to build sustainable local-led programs. So he'll be covering this topic from the evolution of radiotheranostics to how we can build sustainable local-led programs. So yeah, I'm going to hand over to him. As I mentioned earlier, please, if you have questions while he's speaking, put the questions in the chat. And after the presentation, we'll have a lot of time to discuss your questions. So I'm going to stop sharing my screen now. Thank you so much for joining us once again. And I'll hand over to Dr. Mahipal Rathod. Please correct me if I didn't pronounce your name properly. Please, I want to advise that you kindly mute your mic, please, so that we can hear the speaker properly and it doesn't affect our recording. All right, so over to you, Dr. Rathod.
Thank you so much for the introduction. Can you hear me okay?
Yeah, we can hear you.
Okay. Thank you. So I have no conflicts of interest to declare. What we'll be covering today is just, as outlined in the intro just a series of six areas of focus, and in looking at Africa at large, but we'll go a little bit into what we've learned from our work in Ghana. That was a 4.5 year journey, so we'll be sharing some takeaways and key lessons learned, and a lot of clarity in hindsight. So I'll just begin by talking through a little bit of what's happening in the radiopharm landscape on a global scale. So you'll see some schematics. This one's namely for the United States, and you can look at this from 2024 in July. You could see a lot of molecules moving towards the center. The FDA-approved agents, you could probably include radium in there, in the United States. Those are really centrally the three in approved status. And then beyond that, when we go further outward for therapies, you're seeing a lot more development with lutetium, actinium, lead-based molecules and other proteins and antibodies. Um, when you move forward to May of 2025, you see another influx of a lot more players, continued strong development on the lutetium, actinium, and lead. You also see copper, astatine, others listed here. So all of those are in play, and we'll talk a little bit about their various supply, um, you know, and support mechanisms across the enterprises that service the various continents. So when we look at April 2026, we're still looking at the US players here. You're really seeing a massive growth in all modes of development. So more isotopes being identified, a lot more advancement into advanced phases. So moving from phase 2 to phase 3, a lot of studies are taking on. So some things like actinium are scaling, but they're struggling to somewhat keep pace with what is happening. I think those things over the short term will be met by capacity building. When we look at Australia and Asia, here's another schematic, and Nucleus has put together a lot of these, so it's easy to kind of look at them in a comparative fashion. When we look at what's happening in Asia and Australia, you'll see a lot of the similar trends where things are just becoming more and more commonplace and easier to access when more and more sites can execute trials. But looking at the standard of care is really the key focus, because if you can do the basic commercially available products effectively, you have a foundation to build upon. And vice versa, if you've already done a lot of clinical trials, it's easier to onboard something you've already done in the trial space and when it commercializes. So some areas of the globe have evolved in one direction, others have evolved in the opposite. And when you look at Europe, here's another overlay of what is happening in the space. So strong movement. Of course, lutetium is one of the most common, actinium following in tow, and lead-212 becoming more prominent. Of course, supply issues need and scalability and generator-based systems need to be ramped up. So when we look at RLT, we went from, in the 1950s to from I-131 base to current state, where we're seeing, multitudes of both diagnostic opportunities as well as the therapeutic agents that can be used to target these receptors. So as we phase through, we had like the Bexar and the Zevalin in the early 2000s, and then the radium kind of came into play for prostate, and then the dodatates and the PSMA really shifted drastically in the 2018 to 2022. And as of more recently in the United States, we've seen more and more advancement to become used first line. So especially with the PSMA, we're seeing that you can use it as first line pre-chemo, and now we're seeing hormone sensitive indications. So all of these things are moving faster and further forward for the patient accessibility. So centers are scaling in various capacities. One of the biggest pieces is infrastructure. It's difficult to scale, especially when this many things are moving towards the finish line. And so in current state, we're looking at a snippet of Africa. There's close to 30 nations where RLT is accessible, and we're going to go over some of the capacity, including cyclotrons and PET CTs. Here's a snippet of SPEC CTs across Africa around December 2025. By no means would these be all-encompassing, but these are recent peer-reviewed references. So we can look at, there's areas like South Africa and Egypt And up north, it's really, pretty well differentiated. But when you look at sub-Saharan Africa, very sparse. So if you look to Nigeria and Ghana, you can see some disparity. Here's a side by side of the spec CTs and the PET CTs. And when we look to this, I kind of highlighted Ghana as a comparator with, almost a similar profile. I do understand Nigeria's advanced a few more on the PET CT side of things as of late. So this is certainly getting updated and edited. And we take this a step further. This was an IAEA map at the end of 2024 looking at population density across the continent with the RLT axis kind of being spread out pretty far. This isn't a, what I tried to do with this slide was trying to get an overlay of the disparity of population density and access. And if you look at the dark blue phases are, especially if you're looking at the focal point today, we're talking about Nigeria, massive population density, but you have a very limited ability to service that massive population. So the healthcare disparities are very prominent. The number of experts able to service that, as well as the infrastructure, they have to be complementary. So this is hopefully a visual that can drive some conversation. When we look at a global list, SNMMI maintains a pretty concise list of active clinical trials. So on the diagnostic side, you see over 1,400 clinical trials. On the therapeutics, we're about north of 450. I think it's 459 as of yesterday. And on the theranostic side, we're about 131 trials. So in the beta space, you're seeing a lot of leading things happening, radioiodine based and lutetium very strong. The gamma is really just the core low energy stuff that's really been kind of at the core, not really changing much. But on the alpha space, you see things like lead-212, astatine-211, some early work with terbium. So all these things are driving more and more early phase clinical trials, but they require more and more complex infrastructure to be able to get them to the bedside. So we're going to shift gears into just looking at what we had learned from our work in Ghana, and I'll kind of walk through what that body of work was. So this is a 4.5 year journey that ended late 2024, and the first kind of boots on the ground assessment didn't come until May of 2023. So in the years preceding that, there was a massive remote site support with educational materials. They were hosting the folks from Korle Teaching Hospital over at many of the national conferences here and at ENM, SNMMI, and some of the therapeutics conferences so that they could tour facilities, look at programs, go to educational seminars, get applications training and best practices from peer-to-peer exchanges at those forums. So during that Ghana delegation, we were able to inventory for the first time an on-site survey of imaging equipment, looking at the level of training that the staff had. We were able to engage with providers in sessions talking about unmet needs and disparities and where the patients are routing from geographically. And then we also looked at, use of equipment that had been sent there prior. So one of the challenges you'll notice is region to region, the regulatory as well as the logistics, having things clear through customs, and those timelines can be lengthy and they can be very convoluted with a lot of bureaucracy associated with them. And that's evident everywhere, but some areas are more difficult to navigate than others. So we did encounter that firsthand in both delegations. We also did some infection control review and oversight, and we did a lot of focus on the hot lab because there was a massive opportunity there. So the hot lab QC focus for ITLC, tech moly generator, profile, basic radiation safety and protection. And we did a lot of workflow maps and optimized the day-to-day QC instrumentation. And we really took inventory of what the next step would bring to take them to the next level. And we did get very dense in the weeds with the Korle team. One of the key highlights of that initial period on the ground, there was the first RLT theranostic infusion done in Ghana during that time, which is a huge for the region. And then also the first myocardial perfusion imaging testing was also done in that window. And on the right side is just a few images of what was going on. That top left image On the right is the first RLT patient done there. So if we're looking towards what we took away from that first delegation, we were able to inventory something that we could not do virtually. So I want to re-stress the importance of, I don't think you can do one or the other, but remotely assessing a site and then doing a site walkthrough in real time are two distinctly different viewpoints. And I think you have to combine those. I don't think they're mutually exclusive. You have to combine what you do in each of those and bring it together. So after that first on-site, we really came back with things that would bolster and augment. So there was a lot of general radiation safety equipment cataloged here on the right as just a general reference. But the big things that we identified were things that were very low hanging, really would move the needle forward, and provide basic, radiation protection, optimize day to day and the patient flow as well as the personnel flow and essentially the materials flow and all those things integrate into a fluid, very robust process if you dial it in correctly. Um, Software and IT was identified early on, and we were able to make some impacts there. So if we fast forward to the 2024, that was after all that equipment got shipped, we were able to do setup and training on the NMIS system. We selected a lot of these systems and interfaces because the team came stateside and was able to see all this in use. And we figured that when we set them up, the same software that they have is very easy for us to troubleshoot because we're able to remote in and provide remote support whenever they hit snags. So we did a lot of that. We got the NMIS set up. While we were there, we had EC Squared do the user training while we were there for just troubleshooting user access level permissions. And then we did equipment setup, everything from instrumentation, survey, meters, as well as just setting up the workstations for clinical day-to-day use. We also were able to take a very focused approach on radioiodine workflow, helping reduce exposure in that realm. And the generator systems, we increased the shielding and the flow of materials to reduce personnel and patient exposure in the proximity to the work being done. And then as far as provider education, we were able to set up sessions to educate the referring providers of the availability of things like breast lymphoscintigraphy using nanocolloid, which is available there. And we were able to set up supply chain logistics to sustain that after we left. So they're still doing heavy usage of nanocolloid for breast lympho. And we were able to meet with OBGYN and some of the leadership at Corlembu to kind of stress the importance. I think partnering with your executive sponsors and the leaders that would govern the ultimate decision making, they're generally pretty far removed from the work itself. So even getting to know which stakeholders need to be involved, like medical physics, radiochemistry, the technologists, the nuclear medicine attendings, radiopharmacy, all these make up the continuum that services the patients. And to the right, you have some snippets of this delegation's work. So what began early in 2023, we sketched out a simple diagram in our departure to land in 2024. We actually had a little more of a structure around how we wanted things to be oriented. And to the right, you actually see some of the finished product. We were able to go from a very rudimentary setup to then just slight tweaks using existing equipment, additional equipment and shielding being supplied, setting them up to kind of just, have a very efficient flow and a pretty compliant. We have a generator housing apparatus, the I-131 shielding. That larger picture was able to store the ablation doses, pretty high energy being emitted prior. And once we installed the shielding, we were able to get background, very low level. So we have our shielded refrigeration for them and also shielded drawers for the various kits being prepared or anything that got contaminated could be decayed in space. When we went down past that second delegation, I think one of the key takeaways was lessons learned, not only from the first delegation, but what we came and saw the second time. Because I think those two experiences, we learned a lot of different things. We were there for a much longer period the first go around. But things like having a customs delay on a generator for technetium can be, kind of devastating to the number of patients you can service. And that happened both times. And really, there's no control over that unless there's pressure exerted on the agencies that would permit release. Even materials that were donated were sometimes being taxed and levied. So I think we worked through some of that regulatory burden at the import-export side of things, but we were able to partner and get the materials released and to the site. So when we talk through what the impacts were, these were the key discussions of all the things that were done and things that we could continue to do. So with the software, that was a game changer. Data security increased, patient privacy information was able to be digitized. There's a lot of capability now to integrate to imaging software, and that's a future state they're examining. User level permissions were to a degree configured, and I think adding radiation safety and physics to document and catalog all the hot lab functions and the regulatory frameworks to keep it going were also another lift for them. As far as future delegations, general physician facing follow-up was requested because our engagement with the groups for the lymphocytography and the OBGYN really drove the awareness and the capacity to utilize nuclear medicine as a tool. And now they're, very much in favor of continuing to leverage that modality. Going beyond that, for clinical and operations support, sharing of examples was happening at a frequent cadence. I think it kind of went away. I think reviving that would add massive value. We were able to do peer-to-peer case exchanges from a lot of leading centers, and we'd share rare cases examples, and we'd kind of walk through what we all thought. And I think those are extremely engaging, very educational and informative for the kind of like the global partnership that was there. A lot of cancer centers were participating in that. And when you look at the processes and culture and other things, just a culture of like radiation safety, early education, ALARA training, so basic radiation fundamentals, but also how these things work in the day-to-day, but also waste management and process of appropriate shielding when in use. Also, the cardiac case management and education was a key piece identified for education. And then regional challenges we alluded to, kind of getting things released in a timely fashion to service the patient needs is always a key factor. When you get down to the impacts, we were able to have a massive reduction in radiation exposure by way of all the equipment, the training, and the workflow optimization. As far as the automation, the software did a lot to go from paper-based to digital patient profiles in NMIS, and the patient records are now in a compliant fashion, as well as great reporting capability for inspection reports. So the Atomic Agency in Ghana, would have ease of access to that. As far as workflow optimization, there's a lot more needed, of course, as always, for equipment and training. And radiation protection, especially as these novel isotopes continue to have different varying profiles. A lot of the high energy emissions can be devastating if you don't have infrastructure or shielding in place. And then when you go further beyond that, the referring physician engagement is really your referral pattern. So identifying where your patients are coming from, maybe it's not as robustly defined in some regions, and certainly can always use some work. And then the future support for the continuity, virtual sessions. These happen on an ad hoc basis, and certainly site support for troubleshooting day to day. We really got to a level where we were able to have a very candid relationship with our colleagues over in Ghana, and we're on a first name basis. We call each other and speak to each other frequently, even helping sourcing kits when there's shortfalls due to conflicts in the Middle East. You could not get certain coal kits. We were able to help route kits from other regions to support the patients. As far as going through cardiology and additional groups, it was well received, highly productive, and I think they would welcome more of that. And there's a lot of publicized impact reports on that. In the future focus, there's additional sites, and all this work is still in planning. There's another delegation in the works. So all these things will continue to scale and leverage. And you'll notice that, gallium-68 based seems to be of focus, and we'll get into that. But really having a cyclotron is a big undertaking getting it installed and active. If you have access to germanium gallium generator systems, the generator based are seriously a game changer. So the technetium generators are pretty well versed throughout the continent in the SPECT-CT realm. So that would translate over to serviceability of a PET-CT camera without a cyclotron. I think gallium is really your modality to pursue. As far as looking at other sites, Sweden Ghana Medical Center, has a cyclotron in place. They're making F-18 based items, and there's additional scalability in the works. And the Korlebu is a strong partnership with them. So I think that partnership will continue to be more robust. And the Confanoche in Kumasi is also a similar site in need of support. They have a dormant SPECT-CT that is in need of activation and the technologist and physics support. So when we look at the impact report summary, we kind of covered, a lot of the benefits that we got, software, shielding, cardiac stress support. We looked at the use of intraop surgical probe, that training, as well as educating the providers for Sentinel node. I think that was hugely impactful based on all the feedback and providing technical resources, training materials, reading materials, hands-on training and software training. All of those things leveraged the team that is there doing a lot of work to be able to be more optimized in the work that they do and give their time to patient care and less redundancies. So when we look at the workshops and the opportunities to have them come stateside, we were able to do a lot of that. They were able to tour a lot of leading facilities in North America, including GMP facilities, academic cancer centers, centralized radiopharmacies, the BAMF facility in Grand Rapids. So I think they really had a robust tour of very state-of-the-art facilities to take back takeaways that they could go back and institute. The technologist training is really at a global need of it's at a deficit in terms of unmet needs globally. We need more technologists. We need more training for technologists, and I think there's a lot of variability in the level of training. What I can say is like they were fortunate in Ghana to be able to have a robust training partnership with a lot of centers, including sites in South Africa, where they were able to go for months and get a lot of heavy training on the radiochemistry, radiolabeling, and radiopharmacy side of things. When we look to future directions of emerging therapies and technologies that we would look to adopt for Africa, lutetium is really the mainstay for now. Radium is really also going to be commonplace. Actinium is scaling, but really just not fast enough to keep pace. And we feel that's palpable given the number of clinical trials. We see direct impacts to certain patients who have to be rescheduled due to supply disruption. Lead-212, very challenging to deal with. The short half-life and the impurities add a layer of complexity that is probably not easily scaled by small or community sites with ease. A lot of triaging is needed to onboard something like that. Copper is really starting to become more and more prominent. I think the commercialization and the scalability looks to be on the horizon. And then terbium, of course, there's like a multitude of terbium variants, but I think the production infrastructure is not mature. When we look at astatine-211, here's another promising therapeutic isotope that is, this nuclide shows promise. I think these scale limitations exist, but I think as with anything, over time will improve. The tech moly for the diagnostic really been around for a long time, limited to reactor, supply, but that will change also. Iodine has been pretty well-rounded, and zirconium is, preferred because if you can get access to something that's longer lived, stable, good imaging profile, it's definitely preferred because it gives you a more forgiving ability to onboard something, more stability. And when we look at lessons we learned, looking at opportunities for not only Nigeria but Africa at large, I think workforce shortages are every center everywhere has expressed this. The amount of growth in the nuclear sector on a global scale from the first few slides I shared, it's extremely difficult to keep pace with that. You had a period of dormancy where there was not a lot of movement happening in this field, and then you had this massive expanse in the kind of 15 years that led us to now. And I think no one could have predicted that level of growth and investment. Some of the largest mergers and acquisitions are happening, causing, a lot of investment in this space. But does that further extends the specialists that exist? We also have a large workforce retiring. We have a lot of new entrants into the space, and then it's really kind of scaffolding that. But you'd caution sites to be judicious with what they onboard because you simply can't do it all, but you want to be selective and efficient in what you do bring on so that you can sustain a good foundation and then build from it. When you look at infrastructure limitations, this is also resounding across every continent. Infrastructure capabilities from hot labs, injection rooms, appropriate shielding, training, software, and systems and your supply chain logistics. How can you get access to certain products and their serviceability and in quantities that can function and sustain patient volumes? That's a big challenge. So readiness assessments are key. One of the other pieces are just multiple supplier relations. Some areas are fortunate enough to have service recovery from a multitude of suppliers. Other regions are sparse, and Africa has high densities in some areas. But if we look to Nigeria, they have some recovery, but it's not adequate. Same thing with Ghana. So I think massive infrastructure investment will continue to be needed. When you look at the regulatory frameworks, I think this is a very big blind spot for a lot of places, only because it varies so drastically from region to region. I'll give the example of the United States. You can have the federal, then you can have the state, then you can have the local, even at the county and city level. So you can have 3 or 4 layers of regulatory just on radioactive material use. And that's no different for, parts of Africa where each atomic agency will defer to the IAEA, or they may have a layer beyond that that they would enforce. So it really becomes a necessity when you're building things out early. So you have this all squared away before you run into a regulatory issue. When you look at manufacturing constraints, you want to continue to do regional production capacity. The shorter the half-life, the less forgiving it is. And as you see with the imaging isotopes, generally speaking, they're on the shorter side. Some of the therapies are now even short half-lives. That becomes a very big constraint. So when we look at what you can get your hands on, you really have to be selective about what you can source and source with dependency. And reliability. And when we look at supply chain, contingency is really the word that comes to mind with anything radiopharma based, because everything is working against the clock. It's just-in-time care. You're managing the flow of an isotope from manufacturing to the bedside and the patient's journey to convene at a very specific time point. And sometimes those things do not align as we plan. And the recovery is sometimes not possible, and it's not very great for the patients or the providers. The waste management is an often underlooked piece, part of the infrastructure and capacity, because waste and the daughter nuclides that can be contaminants that are longer waste hold times, that can create a massive issue for sites because it has to be compliant and safe to store these and decay them in place. When we look at operational workflow failures, there's a lot of opportunity where you can really accountably list roles and responsibilities by practitioner and then use site readiness checklists, doing dry runs, rehearsal simulations before you actually do a first cycle or a first patient is extremely helpful because you identify a lot of opportunities and gaps. Financial pieces really are so widely varied across Africa. There's nations where there's really no private payer. I think Nigeria is an example of that. When you look at some private payer mix, you know, uh, or self-pay, that's other countries that show that. Your patient referral pathway is pretty key because you have to know where your patients are coming from, both regionally and which providers are sending patients for either RLT or imaging. So as far as takeaways, how would you build a roadmap for a sustainable program? You'd start with a site-specific checklist. I cannot understate the amount of focus you should have on a virtual assessment as well as an on-site survey. And I think a multidisciplinary walkthrough is the most valuable. You would want, radiation safety, the medical physics, of course, the physicians, the technologists, radiochem, radiopharmacy, depending on your configuration. I think those would lend themselves to a robust ground floor plan, and then assigning the scope, looking at the patient's journey and timeline, and then looking at the feasibility of how many cases you can accommodate based on your facility ability to image and the number of injection slots and how fast you can source the radiopharmaceuticals. And then planning towards implementation, uh, aligning and involving all stakeholders early is extremely important because it takes a lot to undo and redo in this landscape. It's very costly. And, really just looking at a very snippeted method, you want to assess everything that you have today. A lot of times you want to wait until everything is at a ready state or at a steady state before you launch. I would urge you to take an inventory of what you have and know exactly what you have in current capacity and capability and expertise, and then make a list of the unmet needs. And then look to your partners like, Oncidium and the global entities that support outreach to build on your local peer-to-peer in the region and internationally. I think you'll find that there's a lot of people willing to help. As far as the planning goes, you really want to look at what is your future state. You should have really like a 30, 60, 90-day plan, pretty much what I covered on the last slide. But then you want like a 1 year, 3 year, 5 year plan. And all these things can vary so greatly depending on your region, budget, the local versus international investment, private versus government. All these things can influence the speed at which things move. Your infrastructure readiness can determine, will you have downtime when you build your new facility, or are you building a separate new facility and then migrating? Moving a radioactive operation is not a small undertaking, so very big consideration there. Enabling the workforce, regulatory readiness. This is where your regulatory folks and rad safety, your physicists, and the folks who are touching the patient on the date of infusion or imaging, they all have to work cohesively to be the enablers. Operational workflow optimization cannot be stressed enough because any inefficiency can lead to a missed opportunity for every patient at every cycle date. And then clinical operations is really something you have to do continuous improvement all the way from program launch, and you always have to include all stakeholders, and you really have to kind of revisit where you are. Your program is dynamic because this landscape is dynamic. The work is really never done, and I don't think we're going to run out of things to tackle. And then scaling, that's once you have all the other pieces well laid out. Scaling is a proposition. So if you have a robust plan going in, you should have a phased approach to scale. And I think that will give you a very robust foundation to build your future RLT program or start one. I've listed here some of the really, things that I found were really must reads for our landscape. You'll recognize some of the names. These folks need no intros, and I think I'm hopeful that this would be meaningful, drive some meaningful dialogue, serve as a reference and a toolbox for you. And I hope this has been informative. I'm happy to take questions.
All right. Thank you very much, Dr. Rathod. Did I pronounce the name properly? Is it Rathod or Rathod?
Rathod,
Hello, can
yeah.
you hear me? Can
Thanks.
anyone hear me?
Yes, yes, we can hear you.
Yes, we can hear you, I can.
Okay. Okay. I wasn't sure. Thank you. Thank you. All right. Thank you. I think there's a lag on my end. I love that you're able to share your experiences from Ghana, which is just very close to us here, so we can all relate to what is going on there. We have some questions. Put them in the chat or in the Q&A box. I see a lot of people asking about certificates and recording. Please, that will be sorted out. So you get your certificates and you get the recording. But please, can you ask questions that are related to what he has just presented? All right. So the first one here is, I want to thank this person, Mr. Andreas. So he says, first of all, congratulations on the first radioligand therapy infusion in Ghana. How many lutetium PSMA treatments have you done since then, and how many patients do you have currently? What's your experience main opportunities, barriers. That's a lot of questions loaded. Um, yeah, maybe we'll just start from there. So how many patients have you done since your since the first infusion, ligand therapy infusion in Ghana?
So I believe that was the first. I think beyond that, it's just been radioiodine. I think the infrastructure is being built out in partnership with the Sweden Ghana Medical Center. The physicians that are at the Corps Lebu also go back and forth between the two, so they have a strong partnership, but they've not been able to scale the RLT component. So that was really just done with a lot of the global presence that was there during the ICRT warmth. Dr. Maharaj, who was our the speaker today, she was actually the one that administered it. So I think, and Professor Mike Sateki from South Africa. So I think that we had like a lot of big players from the global radiopharmaceutical space at the helm, and I do think we want to welcome more of that. But I think there's a lot more education, infrastructure, safety training. But I think the biggest challenge we see for Ghana specifically, if I'm speaking about it, is getting access to the isotope and being able to radio label it in-house. We're a little spoiled in certain markets where you have ready to administer radio labeled product that has been manufactured and sent for administration. I think there other areas do not have that access as yet. So I think that's a regional limitation. I do hope to see that in the coming years we'll be able to scale that. We look at entities like Zenopia, NTP, certainly ITM, Lantheus, Curium. They have a presence and they do service a lot of things based on some things that they've taken over, like Monroe for generators and coal kits. So I think in regions that are underserved, I think the lion's share of growth will happen to sites that can radio label things themselves because they can source the isotope, they can source the molecule, they can prepare it extemporaneously, and that gives a lot more control over something that's manufactured, shipped, and gets delayed, and can approach expiration maybe before the patient can get it, or if it's held up in an import process.
All right. Thank you very much for that response. I was going to add that next week we're going to be discussing some of these things in details, infrastructure, policy, and all that. I don't know what your schedule is like, Dr. Rathod, but it'd be nice to if you can join us, so that we have someone from sharing
Absolutely.
Ghana, we have someone from Kenya and Nigeria. So it'd be nice to have that completed. Okay, let me just go to the next question. You
Of course.
mentioned import clearance of lutetium-177 from customs successfully done. How fast is that process here, Ghana, but also in the case of Nigeria? What's your experience? Okay, maybe you can speak for Ghana. I was going to call on someone to also speak on Nigeria too. Dr. Kolade, I don't know if I saw him on the chat. He was one of our speakers last week. Maybe he can also just comment on the Nigerian side of things. Okay, please go ahead.
Yeah, as for Ghana, I can say I don't know if any of my colleagues from Ghana are on here, but I will say it's not a swift process by any stretch. And each time you get a shipment, it's a different flavor of complexity, just depending on who you have to deal with. Maybe it's someone at the clearance, or there's some kind of shipping constraint or hold up or the flight. So there's a lot of local issues at play, and depending on the agency that's overseeing the release or the transfer.
All right, okay. Um, so do you rely solely on PET-CT for patient identification for radioligand therapy or also technetium-99m PSMA scans? If yes, would you also use it for MSHPC? Okay, that's metastatic hormone-sensitive prostate cancer patients.
I think with the access being the top a theme across Africa. Technetium label PSMA, technetium label products are ubiquitous and readily accessible for the most part. I think this is the easiest thing to turnkey. So I would encourage folks to tap into that. Certain markets don't have access to tech labeled labeling modalities, and they're reliant on PET CT. So again, based on your imaging equipment and infrastructure, your SPECT CT versus SPECT CT camera load, and your serviceability, I would foresee that the sites that are starting to scale should get in on the ground floor using a multi-tech generator to supply their imaging needs until they build up PET capacity. It's such a significant cost when you install cyclotron or PET manufacturing.
Excellent, thank you. What's your take on rhenium 188, could it become a broadly available isotope replacing lutetium-177 in lutetium PSMA as a decentralized alternative?
I don't see that there's enough body of evidence to sustain a scalable supply chain. Certainly, when you compare it, not non-comparison to lutetium, I think lutetium has one of the more robust, certainly if not the most robust in their RLT space today. I think actinium will be a close second. Lead-212 will be some time before we see scalability because they're struggling with trial-based amounts at the moment. So I think, and also region to region variability, I don't know that it's going to be a top prominent player. I don't want to dismiss any particular isotope because we've seen things shift in very sporadic fashion. But I do think that, if the consensus is correct from the national and the international community, those are really the players we are seeing that kind of like what I alluded to as the real main players. I think regionally, if you have a very specific lab that can service your needs, you may be in luck and be able to leverage that opportunity. I don't think everyone is so lucky.
All right. Before I ask the next question, I can see that someone from Ghana commented on the question we asked about the number of treatments. So I'm just going to read it out from the chat. This is by Boye Hammond. So he or she said that since the initial treatment, we have had one more lutetium-177 PSMA therapy completed
Excellent.
last week, and hopefully with the assistance of Oncidium Foundation, we have two more therapies scheduled for September.
That sounds excellent.
Hello. Uh,
I think there's some
And then,
static.
and question, sorry, who is that? I can't see anybody's hand up. So,
Oh, I can hear you. I think it was
okay,
just a
let me just ask
connection
my
issue. I
question.
can hear you now.
All right, okay. After treatment with lutetium-177 based RLT, and in regards of patient release, collection of liquids necessary, direct release in public sewage, patient instructions after release, outpatient, etc. So what are regulations for waste management?
That's a great question. I think it's such a specific question based on your region. We see a massive variation between Europe and North America. I think our colleagues from Ghana can speak to this because it's not a large body of work to demonstrate. So one of the advantages of you have an atomic agency that isn't very mature in how they regulate radiopharmaceuticals, but if they're just licensing at the nucleic level, just by radionuclide, you have some flexibility with how you manage the quantities and what you do with them for human use, but also generally speaking, the waste would really just fall under what isotopes you're handling. If you're talking about lutetium, the general precautions are included in the product labeling, but when you're looking at region, it can vary drastically by state to state, county to county, country to country, and certainly in the continent, every country has a different if they're not looking at the IAEA, they have their own atomic agency. They're going to defer to that standard. So I think it's a widely variable answer. I don't think I have the specifics for Ghana that I can answer as accurately, but Dr. Hammond, I don't know if you have any inputs on that.
Yeah, so each country would have their regulations based on recommendations by the regulatory authority. So, sorry, Dr. Alice, did you want to say something? I saw that you unmuted yourself and your video was on. So Dr. Alice is the scientific director.
Hello. Yeah.
Yes, I can hear you now. Okay, you want to make a comment?
Yes. Thank you, Paul, for the great talk. And I think
You're
this
welcome.
brings lots of information that can be used for Nigeria. So, as City Foundation Director, I just want to say that we are supporting countries to increase the use of lutetium, just like we did with Nigeria and with Ghana. We hopefully will also support that, because it's not only, as Paul said, one single treatment. We need to create an ecosystem, because you can train the people, but we need to have access of the patients. It's not only having the technical people able to do the treatment. And for that, we are partnering with AIA for a second part of Rays of Hope. So to pass from radiotherapy to nuclear medicine, to access to nuclear medicine, and also regarding clinical trials. So this, I think we can build up a partnership with Medicaid to bring more clinical trials. And this is also a discussion from ASCO, Aortic, that I saw during ASCO, to bring more clinical trials, as Paul mentioned in the beginning of his talk. So please, people who have this possibility of bringing clinical trials and training to countries in Africa like Nigeria, reach out to Oncidium Foundation so we can improve the access of these treatments to the countries. Because we have 53 countries in Africa that are with lots of patients in need.
Right. Thank you, Dr. Alice, for that contribution. I see a few hands are up, so please, I'm just going to beg that you spend very few seconds asking your question, because we're already at the hour. So, Boye Hammond, your hand is up. Please kindly unmute him or her, and then afterwards we'll take a comment or question from Hashim Hamed, and then Sham Sudin Said. You can properly introduce yourself when you're unmuted. So, Morgan, can you please unmute them so that they can ask their questions or make a comment?
I just did. So
All right. Okay, so Boye Hammond.
Yes, hello. I hope I can be heard.
Yes, we can hear you.
Yes. So basically, Paul, thank you for the presentation. So I raised my hand to basically respond to some of the questions that came up with regard to Ghana. I think the first one you read in terms of the fact that we've done one treatment after, and then we also have two treatments that are scheduled to be done by kind courtesy of Oncidium this September. And also there was another issue about waste management. And as you rightly pointed out, it depends on the territory and what your regulators require. So for us, for example, our regulators require to have separate waste. So we have different, our sewers have separate waste for hot waste and then non-hot waste. But critically speaking, when you look at lutetium, for example, it doesn't really matter whether the waste is together or segregated. But because it's a requirement by our regulators, we also continue with that. And then I was just trying to respond to Holani Ndlovu's question about whether our regulators require admission or not. And for us in Ghana, our regulators don't require us to admit patients, especially for lutetium therapy. I think the only patients we admit are those who are doing iodine 131 therapy for differentiated thyroid cancers. But for lutetium, they are not admitted. We, however, keep the patients in-house for about 4 hours minimum, and then after that, they can go home once there are no complications or adverse effects that are noticed. And maybe finally, I think there was a question about whether only PETs can be used for as imaging before therapy. And no, we can use technetium PSMA labeling also. Because I remember our first patient who we treated with lutetium PSMA, we actually imaged with technetium PSMA, and the treatment was based on the findings on the technetium PSMA imaging. Now we do have PET, so we are doing a lot of F18 PSMA imaging locally. But when you don't have the PET and you don't have your PSMA, you can actually do your technetium PSMA, which now there are lots of companies on the producing the code kits for the technetium PSMA. Thank you very much.
Thank you very much for that contribution. Hashim Ahmed, and then please, if you can just be very quick. Please, can you unmute him or her? Hashim Ahmed.
Yeah, do you hear me?
Yes, we can hear you now. Okay.
Yes. Hi. Thank you for this kind of interesting topic, which is, I think, is very important right now in Africa. As we see, I mean, there is a lot of kind of disparity between, I mean, those who can afford it and those who are not. And thank you for Ansidian is taking kind of like an initiative to help those who are not in need and being prepared for this. Regarding your lutetium in Ghana, I mean, I'm just wondering, do you do kind of dosimetry, implementation and quantification before you do any sort of like, I mean, therapy and after therapy? Hello?
Yeah, we can
I'm
hear
sorry.
you. Dr. Paul,
Yeah, did you get me? Because I'm right now, I'm writing kind of paper, I'm kind of like advancing theranostic in Sudan. I mean, as you know, Sudan is one of the countries who has been affected by war, and most of the infrastructure has been kind of like destructed. But we had in the past, we had kind of like experience of administering iodine 131 and P32 and so on.
Mhm.
So, and strontium and all these sort of things but in terms of regulation, I think I mean, most of African countries, they have lack of, I mean, proper regulation to handle this kind of like new technology or theranostic into sort of like.
That's a great question. I think dosimetry is a top item. I think the level of advancement on the dosimetry realm in the nuclear medicine space is lacking at large. Certainly on the early cases that have happened in the continent, certainly the ones in Ghana, I don't think we had much of an opportunity to go too far down there. But I think the post scans are where some centers are doing, and as far as like an actual dosimetry program, I think those are very early or in the discussion and planning phase. I don't think there's a robust platform or framework that exists. Certainly not in the countries that I've worked with.
Okay, thank you.
All right, thank you. Thank you very much. Finally, Shamsuddin Said. Okay, it's a male. Would you like to unmute yourself? We already gone past we're already at the hour, so we need to round off. Is he there? Okay. I'm just gonna.
Hello, can you hear me?
Yes, we can hear you now. Okay.
Yes.
Thank you for the excellent presentation. My name is Dr. Shamsuddin Said. I'm a nuclear medicine physician from the Teaching Hospital, Katsina, here in Nigeria. I'm actually involved in establishing nuclear medicine services in Odo, Sokoto, and also currently in FTH, Katsina. Yes. I'm particular about patient access and equity, and also to echo the contributor from the EUS actually that spoke about patient access and equity. This is because personally, in most of the patients that I referred for just simple radioiodine therapy, they simply couldn't afford. So how do we ensure? I don't know whether, Prof, you have certain framework that you can suggest on how do we ensure that radiotheranostics therapies remain accessible and affordable for the average Nigerian patient rather than being limited to those who can pay out of pocket?
Yeah, that's a great question. I think it's a difficult one to dive into without additional context. But I do think that with regions that don't have an capacity to cover or insure patients, the patients are really left to fend for themselves. I think that's where you can leverage relationships with individual entities like Oncidium Foundation. They're really patient advocative and really partner with the ambassadors on a global scale to kind of work with, like you just heard from Dr. Hammond in Ghana. They're able to sequence RLT therapy cycles for patients who are unable to access or afford. And I think that is something I would encourage you to connect and partner with. I do think there's other elements at play where folks are looking to do outreach and underserved dose delivery, but I do think it's at the phase of its infancy because I think the scalability and the regional mapping, it's very cost prohibitive, and getting into a new country and starting something like that, I think if the programs were well established, it would be easier to integrate a continuum of doses that can be supplied at low or reduced cost.
All right. Thank you, Dr. Shamshiddin, for your question. And we would like you to join us next week. We will talk about this more in our next session. So I think we're done with the questions. Dr. Paul, I want to say thank you again
My
for
pleasure.
this wonderful presentation. There might be one or two questions in the Q&A box. I think you can just quickly respond to them. I would like to take this opportunity to invite everyone on this call, all 106 of us, please. We'll be rounding up this series next week and looking at infrastructure training and implementation in Nigeria. Like I said, it might be in Nigeria. Nigeria is just a case study because it's the largest country in the continent. But the lessons learned, like we talked about Ghana today, we're going to have someone from Kenya next week, and so Dr. Paul is from the US. So the lessons learned can be implemented. So please don't say because you're not in Nigeria or you're not in Nigeria. This is a global webinar series. So we invite you to join us next week, and we will talk about the how-tos of what we have discussed today and last week. And the registration is free. Please, the same Zoom link you used to join today. And again, for those who were asking about certificates, please, you can request your certificate from Medicaid Cancer Foundation, one of the organizers of this webinar series, and send an email to communications@medicaidcancerfoundation.org. You have to do that by the 27th of August if you want to get the certificate. And the webinars were recorded. Today's session was recorded. Last week was recorded and it's made available to you by Oncidium to be sent to all participants, I believe. So yeah, thank you once again for joining us. While we were speaking, I saw that the Medicaid team joined the call. So if you don't mind putting on your cameras, let's see you. Oncidium, please put on your cameras so that the wonderful people of Africa and the world can see all those who are behind organizing this very wonderful webinar series. Can you turn on your cameras? Yeah. We can see your beautiful faces, your handsome faces. And I also I think I saw Dr. Zainab on the call at some point. Dr. Zainab is the CEO of Medicaid Foundation, Her Excellency, and she's also the UICC president. So we are privileged to have her on this call. Yeah, I can't see the cameras. I don't know if it's my own end, but okay. I can't see the medical team. Can you? Okay, I can even see some of
She
our
was
speakers.
connected.
Okay.
Actually, just connected, but she just removed her camera now, so I'm not sure if she will connect again. Thank you everyone for joining. We will share this recording after the series. We will share all 3 recordings directly to all attendees via email, so don't worry about it. If you are curious, we have an RLT Connect treatment donation program. I just sent the link in the chat. For any questions that were not answered, we will take them offline and we will try to answer them either via email or within the recording of the webinars as well. Thank you everyone for joining, and I look forward to seeing you next week.
See you next week. Thank you.
Thank you.
And thank you so much to everyone.
Thank you, thank you, thank you, thank you, thank you.